I'm just trying to share my screen, but it says host has disabled sharing. You just need to.
I've just got to give you hosting rights. I was just waiting till I hand
so
it
look,
over.
whilst we're doing that, yes, I'm a virologist, and they're very kind words. I'm going to talk to you about SARS, about COVID, and can I just check that you can see my first slide okay?
Yes, that's very clear.
Okay. So look, I guess one of the things I thought about when I was putting this talk together was, what else can you say about COVID that you haven't heard? I think this audience, I'm not going to present our sort of basic research, but I'm happy to answer questions about it because my PhD is in molecular virology, and I also run a large public health laboratory where we do a lot of testing and have done for the last couple of years. But I also thought maybe what might be interesting is to sort of take back a little bit of the discussion to the basics of how SARS, coronavirus 2, causes disease, because that is going to inform a lot of how we go forward in terms of therapies. And so as well as talking about clinical diagnosis and a bit about the genomics of the virus, which I think a lot of people heard about. We all use terms like Omicron and Delta, and we use terms like SNPs and variability and genomics fairly commonly. I'll try and talk a little bit about the virology, and particularly how it's going to inform vaccines and ongoing treatments, bearing in mind that we now have a couple already licensed in this country. So one of the things that's quite important at the start is to talk about definitions. We talk about a pandemic a lot, but really the definition of a pandemic is quite broad. The fact that it crosses international boundaries, the fact that it affects every continent is used often as a pandemic definition. And so really that's what we use. It's quite a broad and simple definition. But bear in mind that things like the virology, the genomics, the disease severity, how immune the population is, none of those really inform pandemics. It's really just involving every continent and lots of people. The other term that's become used a lot is around genomics. We talk about it, Delta strain and now Omicron strain. We skipped G strain. We talk about lineages, and this is important because the whether something is Omicron or whether it's Delta, that is what lineage it is in, probably has implications for how severe the disease it causes is. But more importantly, it definitely has implications for how easily transmissible it is, how the R0 number, if you like. And this is just a sort of brief history of the way I saw it. As I mentioned, I run a diagnostic lab and a research lab at Prince of Wales and UNSW here in Randwick. And I heard about it very early January. We heard about it as this seafood wholesale market in Wuhan. There's a lot of politics that's come subsequent to that, but I'll show you some of the original papers out of Wuhan, which, along with a more recent analysis that's come out of Harvard, that was just published as a preprint a couple of days ago, clearly shows that the outbreak was centered on this seafood wholesale market, and almost certainly arose from the interaction between humans and some of the animals there. Whether they were pangolin or others is really still up in the air. But it was January the 7th of 2020 that it was confirmed. And it was really only a couple of days later, January the 11th, when Eddie Holmes, who's a professor at Sydney University, whom we work with, a nice guy, who knows an awful lot about genomics and who works quite closely with a professor in China whose laboratory did the sequencing of the first virus, Zhang Yongzhen, uploaded the sequence, which allowed us to design diagnostic tests and allowed us to do a whole lot of other work. It was only a couple of days later that the first case was reported outside of China in Thailand, when it was called this new coronavirus and subsequently the disease called COVID or coronavirus disease. And really the first confirmed case came on January the 25th. We diagnosed our first case 2 days later here in Randwick. So that's the timeline, and really since then there have been, as you know, millions of cases, in fact hundreds of millions of cases worldwide. These are all Australian data. These are easily available on the internet on the government website, and I got these yesterday, so they're a couple of days out of date. But basically, if you look at the total cases, really, they were going along in the hundreds of thousands. There was a massive spike last December, which was the emergence of the Omicron strain. The number of active cases, if you look at the top right on this slide, spiked in January and is now well on its way down. And the number of deaths, and I mentioned that some of the viruses seem to cause less deaths than others, on this bottom right, shows that they were pretty stable over 2020-21. And then around about October of last year, the number of deaths went up, initially above a couple of thousand and now approaching 5,000. So there's been now about 3.1 million cases in Australia, which is 12.4% of our total population. And initially, the crude death rate was about 3%. So if we just took the number of deaths by the number of recorded cases, that was about 3% at the start. By the time of Delta, it was about 0.63%, and currently with Omicron, it's about 0.16%. So many more cases, but fewer, and an increase in deaths total, but fewer, a lower percentage of deaths per number of cases with Omicron. So what about the virology, and how does that inform it, what we do? SARS-CoV-2 closely resembles other coronaviruses, particularly those found in bats and particularly in one bat species. And it's also very closely related to the original virus, which is called SARS-CoV, or you might refer to it as SARS-CoV-1, which is more easy to understand. SARS-CoV-1 really disappeared in 2003. There was one case in 2004, which was laboratory acquired. The virus, as I mentioned, genetically is very similar to those found in bats. And there's particularly a golden horseshoe bat, which is a subspecies. It's found throughout Asia in particular, and it's found in China. It's found very close in Wuhan to some of these areas, and it's also collected as part of surveys to look for coronaviruses. It also quite closely resembles viruses found in pangolin, which sadly are an animal becoming extinct because they're trafficked because people like to eat them. The other point that this makes on the left of this figure is that viruses found in bats there are also other coronaviruses found in rodents, and some of these may go through an intermediate host before they go into humans, or some of them may cross directly into humans. And some of these coronaviruses are ones that we now find circulating routinely in the population. They don't tend to cause severe disease. This is rather a complex slide, but it just represents the fact that viruses cluster genomically. So the blue part on the right-hand side of your screen, this circular figure, those are all the Australian coronaviruses that were sequenced early in the outbreak. And down the bottom of this slide looks at the relationship between viruses found in pangolin, viruses found in bats, and viruses found in humans. And the point is that these SARS coronaviruses too cluster between those three species. So whether they emerged from bats into pangolins into humans, whether they went from bats into humans, whether they went from pangolin into humans, whether they transmit backwards and forwards between these three groups, is not really demonstrated in this figure. It just shows that they look like each other genetically. And so the next step is to really try and sort out where they go. Do they go from bats into pangolins and humans? Why does that matter? Well, clearly you do something to prevent intervention between those three groups, or interaction between those three groups. SARS-CoV-2, which causes COVID-19, coronavirus disease 19, arose in Wuhan. There's no doubt that they were the first cases seen. There's been a lot of discussion, there's a lot of politics, which doesn't particularly interest me. But if you look at the epidemiology and the clustering, they were clearly related to the wet market. And before the politics, there was a very good paper from a group in Wuhan, published in the New England Journal as a rapid publication. And it essentially looked at what happened before January the 1st, 2020, between January the 1st and January the 11th, 2020, and then January the 12th and January the 22nd, 2020. And this is looking at people who developed COVID, basically, in those 3 periods. And there's a couple of things. The ages were similar between all those. They were similarly men and women, a slight predominance of men at the start. But what was really interesting is initially the majority, 55%, were known to be related to the seafood market in Hunan in Wuhan. Whereas once you go later, even just a week later, you're starting to get fewer cases directly related to the seafood market and more cases related to other things. And importantly, healthcare workers getting infected and in fact dying. Sadly, a number of healthcare workers, particularly ophthalmologists, possibly because of proximity that they had to their patients' faces, acquired disease early and died from it. And what's happened, of course, is that this is now, we all know a lot about this, but at the time, and I remember this very well, we really didn't know a lot about it. We didn't know exactly whether it was only coronavirus, why some people died, why some people didn't, why some people acquired it and had mild disease, why some people had very severe disease, long-term complications. And it's interesting, we have all now got a language that we really didn't have then, and we have a whole lot more information. And one of the places this has come from is from diagnostics. And these are just some photos from our lab. We get, at one stage, we were getting 7,000 specimens a day. Some of the private labs are handling 15 and 20,000 specimens a day. That's as many specimens as we might handle in a month or a couple of months in some cases. So we were handling a lot of specimens, and we were still getting small numbers of other viruses, things like rhinoviruses and the other coronaviruses. These are non-SARS coronaviruses that cause a common cold-like syndrome, NL63, 229E, OC43 and HKU1. These are all viruses that cause about 1 in 8 of infections during winter. And we were still getting those, but what we were seeing, of course, was the emergence of SARS-CoV-2. Alongside that, we still have a small number of cases of MERS, Middle Eastern Respiratory Syndrome. And what we were doing was still diagnosing those, but as we progressed, the number of daily tests went up enormously. And this is a summary of Australia. These are the figures from around Australia, but New South Wales and Victoria in particular make up the majority. And this bottom report is just from 2 days ago. In the last 7 days, we've tested 500,000 people for COVID. Of those, that's around about 2,200 rather per 100,000 population. And the total test to date is 63.5 million. So clearly there's a lot of testing, and of course with rapid antigen testing that number's going even further. And if you look at our lab, and these are the people in our lab, we run teams, we run blue and white teams. They don't cross over in case one of them is infected. They don't infect both teams, and we can continue to function. If you look between 2019 and 2020, we tripled our workforce. The other thing we did was we tripled our number of pieces of equipment. And over that time, there's been development of equipment that's gone from very large scale processing machines that take about 3 hours to things like this machine, which takes about half an hour. And of course, we've now gone to rapid antigen tests, which people do in their own home. And so we started testing in my laboratory that I direct in January 2020. We utilised standard PCR. As a research laboratory, we made up our own testing. We had a lot of help from a guy called Leo Poon, who's at Hong Kong University. He sent us out his method in early January, and I acknowledge how much assistance we got from them early on. And then, of course, the commercial assays took over, and I've just shown you some of them. We use certain types. There's a whole range of them. We pool our specimens, and we have ongoing problems with things like intermittent reagent shortages and more. Because we use equipment more often, we have shorter mean times between failures. We have staff who are now getting some leave, but for 2 years didn't have any leave. and we have plans for if infection occurs. So there's been a lot of new technology, there's been a lot of data sharing, there's been a lot of governance from things like the Communicable Diseases Network of Australia and the Commonwealth and Public Health Laboratory Network that I belong to. We and others have published a lot on how to more accurately diagnose and characterise the virus. And so there's been a lot of information. And of course, I'm not going to talk a lot about rapid antigen tests. I can answer questions, but simply to say that they've now become the sort of standard of diagnostics in the community. If you can compare rapid antigen tests, and there's a whole lot, this is a paper comparing a Binax test, but they correlate very well with RT-PCR, but they still miss in a low prevalence population. They still miss a lot of positives, and that can be as many as 50% of positives. So although they're useful, they still have problems. We also do serology testing to see whether somebody's been infected previously or vaccinated previously, and we can use different serologies to distinguish between them. Predominantly, these are the enzyme immunoassays that you're so familiar with from other testing, but there are others. And we do see persistence of antibody after infection for 12 months, sometimes shorter, and we also see post-vaccination persistence of antibody for around 6 months. We do see decay in that antibody, and so that's led to the recommendation, which is now quite clear, that you need to be vaccinated and boosted, preferably within a month or so of exposure to COVID, but certainly within 6 months of exposure. And that's really the serological or diagnostic support for this protocol. We did some comparisons. Greg Walker published this last year as a PhD student of ours, looking at a standard gold reference method, which is called neutralization, with other types of tests, and simply to say the commercial tests do perform very well, and they do measure functional or neutralizing antibody. And so although they're not perfect, and by no means would I use these as the only marker of immunity, they do give some idea of the response to infection and possibly of the response to vaccination. Genomics has become a sort of catchword for how we look at variants of concern and how we look at the outbreak. There are now almost 9 million genomes in 2 years of the SARS virus, which are now available on GISAID, which is an international database, and there's a local Australian database called AusTracker, which we contribute to as well. And this really looks at evolution of the virus. And if you look, I mentioned previously the relationship. These are some of the data comparing SARS-CoV-2 from humans with bat viruses down the bottom. Simply how close they are together represents how close they are genetically. And basically, as I mentioned, the pangolin bat, some bat, and human viruses are very closely related genomically. Why is that important? Well, it gives us an idea of origin of the viruses, but when we compare human viruses between humans, you can then look at spread. And for example, this is a map looking at the Delta or B.1.617.2 virus, which we all heard about last sort of October, November, when we had a Delta outbreak followed by the Omicron outbreak. And that basically spread from probably the UK predominantly around the world. And this is a map of Delta spread early on in the outbreak. And of course, subsequent to that, there was spread between countries, not only directly from the UK, but you can use genomics to inform that kind of spread. And we think that spread is due to mutations, that things like mutations that increase the ability of the virus to bind to cells and infect cells and be released from cells and then transmit from person to person. We think those kind of mutations, particularly in one of the proteins called the S or spike protein, those mutations are important in changing the way the virus spreads. And in reality, as you know, the spike protein is that component of most of the vaccines, both mRNA as well as protein vaccines. And that's one of the reasons, because we think that changes in this spike protein are associated with changes in transmissibility. And this is some work that we've just published. The names of the virus are based upon what I mentioned, lineages at the start. So they look more like each other than other viruses. And although we think, for example, down here that the Delta variant was documented early in India, but probably then very rapidly spread to the UK and particularly London, and then spread worldwide. We do think that these mutations are occurring all the time and that these variants are emerging in different numbers in different countries. So genomics has become very important for epidemiology, and increasingly it's informing our vaccine design and also our therapeutics. We've actually sequenced a lot of viruses within Australia until last December. And since then, because of the massive increase in numbers of viruses and the fact that they're all Omicron, we haven't been sequencing all of them quite as much. So what drives this spread? As I mentioned, probably transmissibility, probably a mutation that means that an individual virus is more easily transmissible. It then outcompetes the other viruses, and following that seeding event starts to infect the rest of the population. Excuse me. And what happens is those mutations become linked to others, which may be associated with increased disease as well. In the last couple of minutes, I'll just talk briefly about vaccination. These are some figures taken off the internet. This is not the WHO website. This is a specific vaccine website that simply looked at Australia's 90% and over, similar to much of countries like Canada. But if you look at places like the US, if you look at parts of South America and of course parts of Africa, the vaccination rates are much lower, and in fact as low as 10%. Currently there's 195 vaccine candidates in preclinical development. There's 32 in phase 3 trials, that is in human final trials, and in 10 undergoing phase 4 post-licensure. These are the figures for Australia. There are currently 5 vaccines approved in Australia. Most of them were previously, as you know, the Pfizer vaccine was an RNA vaccine, and the AstraZeneca vaccine was a viral vector vaccine. But there's now increasing numbers of protein subunit vaccines. One of those is approved, which is Novavax. Oops. But in fact, the ones that are coming through, most of them are protein subunit vaccines, and there's currently 14 clinical trials in Australia. As I mentioned, there's over 100 internationally. There's a lot of misconceptions about vaccines. I won't go into all of these because we're getting towards the end, and I'm happy to take questions. But basically, the vaccines don't cause infertility. They do work against Omicron and Delta in probably not as effectively, but if you look at the clinical outcome, it's probably almost as good. They have been rushed, but the number of people involved in trials have been greater than any other vaccine ever trialled. COVID itself is not the flu. It does have a low death rate once you get up to numbers, but particularly if you look in at-risk people, that death rate goes up significantly. At-risk people like the elderly or those who have suppressed immunity. Ivermectin doesn't work. There are no microchips, and COVID can be associated with changes of autoimmunity, and there's good evidence for that, but vaccines definitely don't cause it. So that's all I wanted to say, simply that with capacity building and increasing what we can do, we've been able to increase diagnostics with a lot of clever technology. We've been able to improve diagnostics and subsequently improve vaccines, and social distancing affects us all. And I'd like to thank everybody who contributed to this, and close with a quote from Fred Sanger, who invented sequencing basically, but that basically we can make a permanent contribution, and this is what we're engaged in. I would like the fact that he called himself a student despite the fact that he had 2 Nobel Prizes. So thanks very much.
Wow, Professor Rawlinson, that was amazing. I can't believe you crammed so much information concisely into half an hour. That was absolutely brilliant. I am blown away, and I hope that everyone else is similarly incredibly impressed by this. I have a million questions I'd love to ask you, but what I might do first is if I can ask you to hover your cursor over me and hand hosting back to me, yep. And we might open it and see if anyone does have a couple of quick questions.
I'm hovering over you.
Over my picture.
There you are.
Yep.
Okay.
Thank you, sir. Does anyone have some questions or a question that they would like to ask? And silence came the stern reply. I understand this is actually a very controversial topic for many people. But yeah, I would just like to say again, thank you so much for sharing this. This information is absolutely brilliant, and I would invite everybody to reflect on this and share with this. Here we go. Here's a question for you, Seb. What do you see in future for new variants?
Continuing mutation, continuing changes in the spike protein, which is the target of the vaccines, and likely increased transmissibility with lower death rates. I think that what we're seeing with Omicron is most likely a reduced death rate in the healthy population, but certainly more transmissibility. And so I think that's going to be the change. And the prediction with any pandemic virus is increased transmissibility, lower mortality. And I think that's what we're going to see. And I guess the final comment is mutation is going to continue. There's no doubt that we'll continue to get mutation. That's just in the nature of the virus.
Okay. A question I actually wanted to ask you, if you don't mind, sir. I briefly came across something when I was searching for something completely different. It was actually in relation to a matter for a lawyer with rheumatology at its heart. And I saw a research paper on, and it was women in the older age bracket who had had the AstraZeneca vaccination having some kind of rheumatic response when they contracted the virus. Is that something you've been aware of?
Yes, look, it's been discussed, and that comes down to the autoimmune issues. COVID actually causes a number of things in your immune system, and one of those is that you get this cytokine overload, but you also do get appearance of sort of autoimmune markers and things like rheumatoid factor and ANA. The vaccine itself does not cause that, and so it's interesting when somebody is vaccinated and then acquires COVID. Is that related to them having an exaggerated response in some way and therefore getting more immunity? Or is that simply because we know that COVID promotes autoimmune and rheumatological kind of issues? I think it's the latter. Mm-hmm. I don't think it's related to the vaccine itself. I think it's related to acquiring COVID, because we know that occurs whether it's pre or post-vaccination. And we have no evidence the vaccination makes that worse, but I think it's an important area of research, and there are a number of long-term cohorts that are being followed for things like that.
Wow, thank you. I'm very lucky to have completely avoided catching it so far. Another question that we have here, Sarah, is do you see flu and COVID vaccinations being given together as an annual event?
That's very likely. I think that's what we're going to see. We've gone, as you know, from flu vaccines that were monovalent to trivalent to quadrivalent vaccines over the last few years, to quadrivalent vaccines with immune boosters, things like adjuvants. And there are a number of trials of things like Novavax plus flu. And it's very likely that the reason that people are moving towards protein subunit vaccines is that flu vaccines are protein subunit vaccines, and the manufacturing and the regulatory process for that is simpler. So I have no doubt there'll be an annual shot of flu vaccine plus COVID vaccine or SARS-CoV-2 vaccine.
Wow.
In the future, yeah.
And one last question, sir. What do you consider the most effective vaccine at present or in the long term?
Oh, great question. Very dangerous. Look, I think they're all very effective, actually. If you look, I mean, the original trials were, some of them were 20,000, some of them were 100,000. It's hard to know. I mean, the whole issue of whether you should have an mRNA vaccine followed by a protein vaccine, the evidence is really, it probably does not matter. There may be subtle differences, but at the end of the day, so long as they're raising adequate immunity, they're working very well. What we do know from some of the trials, and again, this is political and controversial. Well, it's political, it's probably not controversial because they've been done reasonably well, is some of the Sinovac and some of the Chinese whole virus vaccines, which you would think would work better because they're whole virus, and you'd think that would really raise a broader immune response. do seem to have a very short period of protection and to not protect as well. And as I say, this then becomes political and commercial. I'm not going to get into that. But if you look at the data, they do seem to have a shorter period. So the whole virus, adjuvanted or non-adjuvanted killed virus vaccines don't seem to work as well as the mRNA protein subunit and some of the others that have been trialled.
Wow. Look, thank you so much, sir. I'll let you get on with the rest of your day. Thank you, everybody, for joining us for this fascinating and interesting talk. The comments are coming through, sir. Everybody found this fabulous. Thank you so much. Thank you, everybody, and have a great rest of the day.
Thanks very much. Glad you enjoyed it. Take care.
Bye.
Yeah.